Have you ever encountered a patient with recurrent episodes of confusion, slurred speech, ataxia, normal brain imaging, metabolic acidosis with normal lactate levels? You made the diagnosis of metabolic encephalopathy without knowing the exact cause. If yes, you may have missed a rare but important diagnosis, D-lactic acidosis. Unlike the common L-lactic acidosis seen in shock and sepsis, D-lactic acidosis is an entirely different disease with a unique pathophysiology and management. In this video, we'll discuss what D-lactic acidosis is, why routine lactate levels are normal in this condition, which patients are at risk, how to diagnose it, and the key principles of treatment. Let's begin. Most clinicians are familiar with L-lactate, which is produced during anaerobic metabolism in human tissues. However, D-lactate is the mirror image isomer of lactate. Humans produce only tiny amounts of D-lactate because our metabolic pathways primarily generate L-lactate. Instead, D-lactate is produced mainly by intestinal bacteria through carbohydrate fermentation. Normally, very little D-lactate is absorbed, and any absorbed amount is slowly metabolized by the enzyme. Problems arise when D-lactate production exceeds the body's limited capacity to metabolize it. The classic patient is someone with short bowel syndrome. This usually occurs after extensive bowel resection, mesenteric ischemia, Crohn's disease surgery, bariatric surgery in selected patients, and congenital short bowel syndrome. Here's what happens. Because much of the small intestine is missing, carbohydrates are poorly absorbed. These undigested carbohydrates reach the colon, where bacteria ferment them into organic acids, including D-lactate. As D-lactate accumulates, it enters the bloodstream, producing high anion gap metabolic acidosis. A high carbohydrate meal often precipitates symptoms. This explains why many patients develop episodic attacks after eating sweets, pasta, bread, or sugary drinks. The most striking feature is neurological dysfunction. Patients may develop confusion, dysarthria, slurred speech, ataxia, difficulty walking, behavioral changes, somnolence, and occasionally coma. These neurological symptoms often appear out of proportion to the degree of metabolic acidosis. Many patients are initially misdiagnosed with stroke, alcohol intoxication, drug overdose, sepsis, or hepatic encephalopathy. An important clue is that these episodes are recurrent and usually occur after carbohydrate-rich meals. Diagnosis requires a high index of suspicion. The typical laboratory picture includes high anion gap metabolic acidosis, low bicarbonate, normal or mildly elevated routine lactate, normal ketones in many patients, normal toxic alcohol screen. Here's the key point. Routine blood lactate assays measure only L-lactate. Therefore, they are usually normal in D-lactic acidosis. Definitive diagnosis requires a specific D-lactate assay, which is not routinely available and often must be sent to a specialized laboratory. Therefore, diagnosis is frequently clinical. Whenever a patient with short bowel syndrome develops unexplained neurological symptoms with high anion gap metabolic acidosis and normal L-lactate, think about D-lactic acidosis. Treatment has several components. Number 1. Correct dehydration and metabolic acidosis. Intravenous fluids improve renal clearance. Sodium bicarbonate may be required if acidosis is severe. Number 2. Reduce carbohydrate intake. This removes the substrate for bacterial fermentation. Number 3. Suppress D-lactate-producing bacteria. Short courses of antibiotics such as metronidazole, vancomycin, rifaximin, or neomycin may be used depending on local protocols and microbial susceptibility. Number 4. Long-term dietary counseling is essential to prevent recurrence. Patients should limit simple carbohydrates and maintain regular follow-up with gastroenterology and nutrition specialists. Remember these 5 key points. D-lactic acidosis is different from ordinary L-lactic acidosis. It occurs primarily in patients with short bowel syndrome. Neurological symptoms with normal routine lactate are the hallmark. Routine lactate testing does not detect D-lactate. Treatment focuses on reducing carbohydrate fermentation, correcting acidosis, and preventing recurrence. D-lactic acidosis may be uncommon, but recognizing it can prevent repeated hospital admissions, unnecessary investigations, and delayed treatment. The next time you see a patient with high anion gap metabolic acidosis, normal lactate, and unexplained neurological symptoms, ask one simple question. Does this patient have short bowel syndrome? That single question may lead you to the correct diagnosis. If you found this video useful, please like, subscribe, and share it with your colleagues. Thank you for watching.